Okay, good morning. Pleasure to be here, and thanks to Lucas and the rest of the organizers for, for the kind invitation. I share the conclusion of Tom, the future is bright, but interventionists were going to be working harder, and that makes it...
So advance with the green.
Thanks. All right, so I've been asked to speak about, or try to convince you about the benefits of direct transfers to Angio suite. Here are my disclosures. So it's all about when we come to when a patient gets to the hospital. Here we're going to speak about reducing in-hospital workflow times. So basically what we need to do with a suspected large vessel occlusion stroke is to confirm the large vessel occlusion and to rule out an hemorrhage or an established infarct. And of course, the way we're going to do that should not be a one-size-fits-all for every patient, and it may vary if the patient is 1 hour away from symptoms onset or much longer, for example. So just to put you in perspective, this is a publication from not so long ago in which in the UK they were measuring the ambition of measuring quality of hospitals, and they were talking about a quality measure is defined as doing a CT scan by next day, right? And it might sound odd to us, but around half of the centers achieve this quality measure. So we can, of course, do much better than this, and paralleling what was done with door-to-needle time, all of you might know this figure in which, as we increase the number of treated patients with IVTPA, we were able to substantially decrease down to 15-20 minutes the door-to-needle time. By doing internal changes in the team, making everybody aware of the importance of cutting workflow times, at Pittsburgh, they were able to reduce from 105 to 67 minutes the door-to-puncture time, which is great, but probably there's how do you call that, an effect, floor effect, right? You cannot go much lower if you do the usual pathway. What are we proposing? So first, of course, promote pre-hospital alerts by EMS, as was said here before, to skip in every case as possible, avoid the emergency room. We could ask the paramedics to bring the patient straight to the CT. We can give the IVTPA bolus in the CT scan immediately after non-contrast CT, and after that continue with further imaging. So this is what we try to do, and by doing that right now, this is well, a few years ago, but still there is there are large differences in this KPI between centers. Some of them are performing really well, and others not so much. And even in one of the most recent published studies, you can see that the door-to-puncture time was not so great, almost 2 hours to decide that the patient is suitable for thrombectomy. And of course, there was the randomization process, but still, these 109 minutes are way too much, and we will agree for this. So let me show you or comment an extreme case. Let's figure that you're going to perform a diagnostic angiogram to a patient that is asymptomatic, and while you're transferring him to the table, he suddenly becomes hemiplegic. And probably most of you will agree that in this case, it doesn't make much sense, if the onset is right in the angio suite, to take the patient out, to bring him to the CT scan, and to take a decision. Probably most of you, all of you, or most, will think that doing a cone beam CT in the angio suite immediately will be enough or sufficient to rule out a hemorrhage. And in the case that you cannot see a bleed, you can start your groin puncture. So the question is, if we allow this and we think that this is fair enough, how much are you prepared to expand this time in order not to take the patient to the conventional CT and just take him straight to the angio suite? Is it 1 hour, 2 hours, 6 hours, 9 hours? Well, that is the question for me, because for me there is no doubt that in the very early time window, we do not need, there is not much benefit of a conventional CT scan. And this is shown by the study that we performed last year. We studied almost 3,000 codes primarily admitted to comprehensive stroke centers in the area of Barcelona. And we tried to see what were, if we could find predictors of endovascular treatment. And as you can see, the bottom line here, the main exclusion for not to get or those patients that did not get an endovascular treatment, they had also very, very high aspect scores. And the bulk of the patients are admitted within 3 hours, at least in our setting. And you can see that the rate of the ischemic strokes remains stable, around 60–70% during the first 6 hours. But the most important is that despite a perfect aspects decreases in the first hours, so your rate of aspects 10 decreases, your rate of aspects compatible with endovascular treatment, which according to the guidelines right now is greater than 5, remains very high, higher than 90%, even up to 6 hours. So in other words, in order to find out this less than 10% of the patients, we are punishing the whole population. We take them to lengthy imaging protocols, and we waste time in all these patients. And on top of that, I think, and we're probably soon going to confirm that performing a thrombectomy in patients with lower aspects, I don't know if they benefit, but we certainly will not harm them. But anyway, this is a parallel question. So the rate of LVOs is also pretty much stable, around 50–40% during the first 6 hours of these admissions. And at the end, 1 in 3 of these patients, 1 in 3, will end up receiving a thrombectomy. If we can confirm that the patient is an ischemic stroke, meaning with a cone beam CT we can rule out an hemorrhage. We did a very fast NIH stroke scale greater than 10, and the patient had a previous good ranking score. So 60% of those ended up having a thrombectomy. So why do I say that? Because, as I said, we try to avoid as much as possible going through the ER. I think it's a complete waste of time going to the ER, then to the CT scan, then back to the ER or to the stroke unit to get the IVTPA, and then another transfer to the Angio suite. So if we are pre-alerted, we avoid this. We take the patient to the CT scan directly, or if we have this criteria, meaning that we are pre-notified, we are on site and the Angio suite is ready, within 6 hours we ask the paramedics to take the patient straight to the Angio suite. And this is what happens. Within a few minutes we prepare the patient. You're going to see how we quickly perform a cone beam CT. Here, now we are acquiring the images. We confirm that this is not a bleed, and we are ready for initiating the procedure. And this, in the Angio suite, this process is extremely short, around 5 minutes. We're able to do that without many intra-hospital transfers. And the quality, of course, is getting better and better of cone beam CT scans. Most of the times enough, well, all of the times I would say enough to rule out a hemorrhage, and we can discuss if the patient on the right should be treated or not with TPAs, probably not, with a thrombectomy. This is under discussion, but we have a good sense of what is happening in the brain parenchyma with this technology. So we started a pilot feasibility study, and we started one day to take all the patients that we could through the direct transfer protocol, and we find out that around 1/3 of the patients could follow this pathway. Another third went straight to the CT, and unfortunately 1/3 still were either not pre-alerted or something doesn't work perfectly, and the patient ends up in the emergency room. So Now, right now, it applies approximately for a third of our admissions or our endovascular treatment, and this is the price we pay. We take to the Angio suite, of course, a higher proportion of patients with no occlusion or with an intracranial hemorrhage. Around 25% of these patients will not be candidates for a thrombectomy. This is obviously a price that we pay, but in return, this is what we get. We get extremely low door-to-groin time punctures, around 15 to 17 minutes for the patients that go straight to the emergency room. And this means saving 30, 40, or even 50 minutes only by doing that. And of course, this should be somewhere around 10 to 15% benefit in the rate of good outcome at 3 months. So this is what we thought. We tried to confirm this. We observed, of course, for all the groups, a reduction in the neurological deficit over the first 5 days. And incidentally, we find that there was a higher rate of dramatic clinical improvement in the patients that went through the direct transfer to the Angio suite. Well, in the same year, other groups worldwide started to do the same. We all published similar protocols. Some of them are using, before the groin puncture, they perform a cone beam CTA to confirm the occlusion. In our center, we prefer to confirm the occlusion with an angiogram, directly with an angiogram. We save extra 5 minutes probably. But both protocols are excellent. And since we, for this study the baseline populations or characteristics were not well balanced, we decided to do a case control study in which we matched the admission variables, especially the time from onset to admission, in order to confirm that there was a benefit. Again, we confirmed a dramatic reduction in the door-to-groin time, and you see here how we were able to demonstrate that we reduced by 12–13% the rate of good outcomes only by taking the patients straight to the Angio suite. So, yeah, of course, there is a price to pay. We need to take more patients there. It stresses the system. The techs, the nurses, ourselves take additional 25% of patients to the Angio suite, and but in return we get a good benefit. So what do we need in order to finally conclude that this is safe and effective? It's randomized data, right? So there are several initiatives that are planned to start. We started our randomized study, the AngioCAD study, 14 months ago. We recruited so far 100 patients, and basically what we do, if we are ready to take the patient to the Angio suite, what we do right now is we randomize this patient. We either go straight to the CT or straight to the Angio suite, and we're going to perform a primary efficacy analysis with the patients in which there was a confirmed large vessel occlusion. Because we believe that the benefit relies in reducing the workflow times, the door-to-groin puncture, but also probably by taking patients straight to the Angio suite, we're going to treat more patients. Some of these patients are not going to be treated after conventional imaging, and well, there might be a difference also there, or the treatment effect might be also there in treating more patients by doing a direct transfer to the Angio suite. Anyway, you can tell me, yes, yeah, that's fine, but maybe you are denying the benefits of IVTPA if you take the patient straight to the Angio suite. Can we treat with IVTPA under these conditions? So we believe we can. We started giving IVTPA to the patients that had no contraindications based on the cone beam CT. And so as we are doing the groin puncture, we are also giving the IVTPA bolus in the arm. And so far, well, when we did this study, we had 20 patients treated with IVTPA. Right now we have over 30 with no major bleeding complication. It seems safe enough. Just keep in mind the trials in which we confirmed the efficacy of IVTPA in the decade of the 90s. The quality of the CT scans was not much better than what we can get as of today with a cone-beam CT. Second, how far from symptoms onset is direct transfer still beneficial, right? It's probably not the same impact if you are a few minutes away from symptoms onset or if you are 10, 12 hours after symptoms onset. So we tried to answer this question too. We did again a subgroup analysis with our case control population. You can see that basically all the subgroups tend to benefit from the direct transfer to the Angio suite, especially more severe strokes, younger patients, and earlier time window here. So why is that? Well, if you can see, here you can see the difference in the ranking according to subgroups. You get the same absolute reduction of time, around 45, 50 minutes, but of course the impact is going to be much higher proportionally in the 0 to 3 hour window. And when we look at the curve of the benefit of direct transfer as compared to conventional imaging, you see that the benefit, the bulk of the benefit, is in the first 2 hours, 2.5 hours, and progressively it decreases. And it makes complete sense to me. Those patients who are fast recruiters, those are the ones that in the very early time window, it makes a difference if we are able to reduce 30 or 40 minutes. Once we are up to 4, 5, 6 hours, those fast recruiters are not going to benefit with either of the options. And this is why the earlier, the higher is the benefit of this measure. Finally, just to show you in relation to the other two speakers, how progressively over the years, these are results from our center, we were able to still reduce the door-to-needle time for IVTPA. We are dramatically reducing the door-to-groin time, and because we are also working with paramedics, with pre-hospital scales, and with improving transferring systems, overall we are reducing the symptoms to groin puncture times over the years. And this reflects all the work that we do in all these areas. And I think this is my last slide. Yes, thank you very much for your attention.